I have a moment here to talk to all of you. So I'm going to take the opportunity. So for years, I have been an early riser and an early joiner coming to the MGH. I've been part of the Dawn Patrol. And so I have been in this hospital for 12 hours a day or more for probably 80% of all the days for the last 40 plus years, 45 plus years. I'm going to start with comments of gratitude. I'm going to start with the people who keep this place clean because I stay late. I know the buildings and grounds staff. I always thank them. They keep this place spotless, and everything is built on the work of these individuals and many like them. In my own office, I've been endowed with incredibly talented, wonderful people, nurses. Many of you know Annette or Kathy or Mary Ryan or Nancy. My front desk staff, Donna, Claudia, Alex is left. We have Flo and Barbara on the other side. And then there are the medical assistants, Vanessa, Patty, Sydney, all wonderful people, all part of the care experience. They allow us to do what we want to do. A special shout out to Linda Lufkin, who has been my administrative assistant for 25 years, a great facilitator. So I've also had the benefit of generations of outstanding leaders. When I came here, it was Alex Leaf, and then John Potts, and then Denny Osiello, and then Katrina Armstrong, and now Josh, who stepped into the very difficult role of being the interim chair of the Department of Medicine. I was also lucky to be led by division chiefs, Al Mully to start out, Mike Berry, and more recently, Josh Metley over the last decade. These are talented individuals who share a commitment to internal medicine as intense as my commitment. I'll say a word about John Stokel. I was very lucky to have the opportunity to work with John, as were many other individuals. He was a great enabler. He was an advocate for this practice, the IMA. He was an advocate for community health care, and he was a role model for all of us who believe that it all starts with the individual patient. My Millennium Project that I did with John, now 22 years ago, was really meant to summarize his life work. But John himself stood on the shoulders of Richard Cabot. The commitment of this institution to the day-to-day care of individual patients goes back for decades into centuries. Within my practice, there have always been inspirational clinicians. Jim Deneen, Peter Gross, Harvey Simon, Cy Hopkins, Ed Maynard, Jerry Foster, on and on and on. Currently, I'm surrounded by incredible clinicians, nurse practitioners, and physicians. I won't name names because there's so many of them. I am a lucky man because I'm surrounded by people who share my commitment, who have the talent and the motivation to take care of patients. I also have an extraordinary family. And at this point, I have to call out my incredible wife, Patricia Willard. Pat is an extraordinary woman who allows me to be me, which is saying a lot because I'm a challenge. I have 3 children, my son, Ethan, my son, John Edward, and his wife, Marissa, a wonderful couple, and my daughter, Molly, and her husband, Kel, a wonderful couple as well. I'm so proud of them as individuals, as parents, as couples. And I have 2 grandchildren, little Teddy, who's now 6, and the little Dylan, who's about 9 months old now. She just turned 9 months. So I am grateful to all the individuals that allow me to be the person I am. So let me just talk a little about who I am. What is my story? Where do I come from? So I was steeped in the traditions of medicine. My father, my grandfather were both doctors. My grandfather was a general practitioner, my father, an internist, rheumatologist, but both of them deeply committed to patient care. I grew up on Sunday afternoons listening to discussions between my father and my grandfather about difficult cases. They would go through and show movies of surgical procedures, bloody surgical procedures. So for me, medicine was comfortable. I knew what it meant. I knew what the rewards were. I knew what it would require of my life. My brother, a surgeon, was ahead of me, also chose to go into medicine and went into surgery as his specialty. Also an extraordinary inspiration to me. So I started out life with a comfort in medicine, but I wasn't sure I wanted to go into medicine. I recently read my medical school application, and in the application, I talk about my own ambivalence about going into medicine. So when I went to college, I got intrigued by history, and I ended up graduating with a degree in social history from Columbia. So this was the 60s. This was a time of great civil unrest, probably as much civil unrest as we're currently experiencing, perhaps even more. It's a very violent time, and I was witness to this. I was at Columbia. This is one of the areas where this stuff was actively going on. So my history was American social history, and my focus was the origin of the Visiting Nurse Association in New York City. Off I went to Stanford, thinking that Stanford was a suburb of San Francisco, only to find that it's a long way from San Francisco to Palo Alto. A beautiful environment, but it was a little bit too removed from the real world for me. So I got involved in teaching a course as a medical student to the undergraduates at Stanford and did research about interest in healthcare reform among different groups of people in lower working class and middle class neighborhoods in the peninsula area. That's when the peninsula actually had working class individuals who lived there. So then after medical school, I came to the MGH through the match, which is this crazy system where you list where you want to go for your training, and you get an envelope one day in March that tells you where you're going to spend the next 3 years of your life. I was blessed, fortunate to come to the Mass General, to the primary care internal medicine training program, where I was again surrounded by incredible individuals, colleagues who I learned enormous amount from. And of course, it was John Stokel who had really laid down the territory of an academic life in outpatient internal medicine. So where does this leave me? Who am I? So there is the persona that you know, which is the patient-facing persona. That's what I do day in and day out. That is who I am. I get such gratitude from that, such reward from that. But then there's the other piece, the academic side. What does it mean to be an academic internist? So I'm going to talk a little bit about education, because one of the things I did at the very start of my career was develop continuing education courses for primary care physicians. That started in 1981, and I've been doing it continuously since then for 1-week courses. Somewhere between 500 and 700 doctors come to Boston. They used to, now it's all done virtually. And it's an opportunity for me to help them take better care of their patients. I do another course called General Medicine for Specialists. These are Harvard courses. And this is for specialists who've forgotten what they need to know about general internal medicine. I've also been involved with the day-to-day teaching of residents. That's what I did this afternoon. It's in the room, hands-on, reviewing medical records. And in the past, I've been involved with the inpatient training of medical students and residents. Again, part of what it means to be an academic is to be committed to education. And doing peer-to-peer education is a challenge because you got to figure out what you can tell people that they don't know already. But I was also heavily influenced by my own personal experiences. And in some ways, that goes back to my experiences with my father and my grandfather, their commitment to individuals. But when I went to Columbia and then I went to Stanford, I expanded my horizon and started getting more involved with healthcare policy. In the 1990s, I was mostly a spectator. In the late 1990s, I suddenly found myself leading a statewide ballot initiative to bring about universal health care in the Commonwealth. It was me against the entire insurance industry. We spent $125,000. The insurance industry spent $5.4 million. That's a 50-to-1 ratio, just to run the math. We almost won. We was a 48-52 spread. After that, I became part of a statewide commission to explore the feasibility of a state-based universal healthcare system. And at the end of that, the consultant said to the group, I'm assuming that healthcare is part of the social contract for the Commonwealth of Massachusetts. Across the room was Barbara Roop, who had worked for Dukakis as governor. And we glanced at each other because we knew there was no such social contract. At that moment, we met and we concocted the idea of a constitutional amendment that would basically make healthcare a protected right, like education is a protected right. We took that through 2 constitutional conventions. DeMacy, Travellini, and Governor Romney knew that our approval was at the 80% level. It was headed to the ballot. That triggered the 2006 healthcare reform in the Commonwealth, that then triggered the 2010 Affordable Care Act, March 23rd, 2010. Just to remind you that for the previous 100 years, the discussion had been whether or not healthcare should be a government responsibility. With the passage and signage of the Affordable Care Act, we crossed an enormous threshold. So we're going to it'll take a long time to sort this out. It's an expensive commitment. But, as little as 12 years ago, people were still saying, well, you don't have healthcare, that's your tough luck, particularly in states that had very little of a social network, of a safety network. Since that time, my focus has been on the workforce. And Josh alluded to my work in payment reform, and this is extended right to Congress. It's extended right to the Center for Medicare and Medicaid Services. And I've been extremely fortunate to have good colleagues and connections that have allowed me to talk to the most senior leadership. Because if we don't bring about parity with physician payment, we're never going to have enough cognates to do the job. So cognates include folks who do primary care, but also think about endocrinology, you think about rheumatology, you think about oncology. I had the privilege of writing an article with Rochelle Walensky that was published at the fairly early part of the pandemic that illustrated how people were dying from COVID and there were no infectious disease doctors anywhere. So the Goodson chair, what's the point of this? So there are 2 parts to this. The first is the primary care part. Primary care means willingness to expose yourself to uncertainty. This is difficult, I'll tell you. When I work with my residents, they're terrified. People go into specialties because they become quite knowledgeable and quite expert in that specialty, and everything else they just say, well, that's somebody else's problem. So you need to have people that are willing to expose themselves to that uncertainty. This is a big, big deal, as you well know, because you as patients are always faced with uncertainties about your symptoms or your findings or whatever. So you need somebody to be there with you during those times of uncertainty. But there's another piece of this, internal medicine. It's kind of an odd word, internal medicine. I think most people have no idea what that means. Well, it really connotes a focus on the inner workings of the body, the organs and how they fit together, the hormonal systems, their neurologic systems, how everything kind of works to keep us alive and healthy. That's part of what the book is all about, is trying to optimize functionality in all those various components. It's different than family medicine, and not to denigrate the importance of family medicine, but internal medicine is more the complicated adult problems. So sometimes patients can be in their 20s with extraordinary complications. But I guarantee you that each and every single one of you, as you have lived your long lives, have developed lots of concurrencies that somebody needs to keep track of. So primary care internal medicine really requires a breadth of knowledge that can be a little bit intimidating. It also requires enough understanding of your specialty colleagues so that you know how to find the right people to do what's needed to be done. So it's the concept of complexity density. That is the work of primary care internal medicine. It's the willingness to expose yourself, and it's the commitment to maintain the expertise and knowledge base to manage that complexity density. So how is this going to happen? How are we going to keep this alive? Well, I think that's really to be determined. And that's really the beauty of this chair, is that it will allow the institution to begin to expand its thinking and consider new possibilities. Recruitment, perhaps, training, peer-to-peer education. It's all going to be important. It's all going to require work. We talk about the need for primary care internal medicine, but we got to figure out how to make this happen in the context of all the other incredibly exciting things that go on at this hospital. So I'm going to end with another statement of gratitude, because I started by talking about all the people around me that help me do the work I do, the support staff, my family, the leadership. But I'm going to end by saying that you, the patients, the individuals that have allowed me to serve as your doctor, have enormously impacted who I am. You have permitted me to participate in your lives, and that's a big deal. To let me be held in your confidence is just a statement of your willingness to trust me. That trust is extraordinarily valuable to me. I cannot tell you how much I appreciate that. And with that trust, I've been inspired to do more, to learn more, to teach more, to be more of an advocate, to push for change, to come in early, to stay late, to answer emails, to write letters, to do prior approvals, on and on and on. You provide the energy that allows me to continue. And I cannot tell you, I cannot even fathom to tell you how important that has been to me. And I thank you from the deepest, deepest part of my heart.